Before beginning the physical examination, the examiner first introduces themselves, clarifies their role, confirms the patient's identity, and explains the intended examination, using patient-appropriate language. The examiner gains consent, providing a chaperone if appropriate, and washes their hands. For a detailed description of how to prepare for a physical examination, refer to the course Preparation for Physical Examination. To perform an examination of the ear, the patient is positioned on a chair in such a manner that the examiner has access to both ears and can easily stand behind the patient during the exam. Exposure is from the neck up, removing any hats, scarves, or high-collared sweaters. A general assessment of the patient is first made, in order to gauge their overall level of health. Physiological parameters should be checked if this information is available. A focused general examination is then performed. Starting at the hands, the examiner looks for peripheral signs suggesting infection or malignancy, and looks for general or systemic features that might be relevant to an examination of the ear or auditory system, such as features of Down syndrome or Turner's syndrome, or scarring from a cleft lip repair. For a detailed description of the various components of a general examination, refer to the course General Examination and Vital Signs. Inspection of the external ear is first performed. The pinna and the conchal bowl are carefully inspected, looking for scars, evidence of infection, obvious abnormalities of the skin or cartilage, including any evidence of skin cancer, such as squamous or basal cell carcinoma. The ear is moved forward to allow inspection of the mastoid area and inspection of the antihelical fold and the posterior aspect of the conchal bowl. The preauricular area is also inspected, looking for preauricular pits and evidence of any sinuses or fistulae. The examiner also inspects for any congenital or anatomical abnormalities of the outer ear, for example, microtia or low-set ears. In microtia, the pinna is underdeveloped and, for classification of the type of microtia, the separate structures of the pinna, such as the helix, antihelix, tragus, antitragus, and lobule, need to be examined individually. Low-set ears can be identified by drawing an imaginary line through both inner corners of the eyes. The helix of both ears should cross this line. If the helix is located inferior to this line, low-set ears are present. For the examination of the acoustic meatus and the tympanic membrane, otoscopy is performed using an otoscope. When the left ear is examined, the otoscope is held in the left hand, and when the right ear is examined, the otoscope is held in the examiner's right hand. Note that the otoscope is held like a pen, between the thumb and index finger. The examiner rests the ulnar side of the fifth digit against the patient's cheek for stability. In adults, the examiner can gently retract the pinna posteriorly and superiorly in order to straighten the external auditory canal. The external auditory canal is inspected for the presence of wax, scaling, inflammation or edema, evidence of discharge, or whether a foreign body is present. Inspection of the tympanic membrane involves looking systematically across all four quadrants, noting the color, shape, any bulging or retraction, and any visible perforation or scarring of the membrane. A cholesteatoma classically causes a retraction pocket in the attic or posterior-superior quadrant of the tympanic membrane, sometimes appreciated as a pearly white lesion behind the membrane. The examiner can also look for a light reflex. In a healthy ear, a cone-shaped reflection of light should be visible in the anterior-inferior quadrant. In the left ear, this is between approximately the 7 and 8 o'clock position. Otoscopy is performed in both ears, comparing one side with the other. In this film, just the left is shown. An examination of the ear should include an assessment of the patient's hearing. This can be performed generically by asking the patient if they can hear better from a particular ear, and can also be assessed by performing Rinne's and Weber's tests. To perform Weber's test, the examiner places a vibrating 512 Hz tuning fork in the midline of the patient's forehead. The patient is then asked on which side they perceive the sound to be loudest. If Weber's test localizes to the better hearing ear, this implies a sensory neural hearing loss, whereas if it localizes to the poorer hearing ear, this implies a conductive hearing loss. Rinne's test is performed by placing the vibrating tuning fork over the mastoid process to test bone conduction. The examiner confirms that the patient can hear the sound of the tuning fork and then asks them to indicate when the sound has disappeared. When the patient can no longer hear the sound, the examiner moves the tuning fork in front of the external auditory canal to test air conduction. If the patient can hear the sound again, this suggests that the air conduction is better than bone conduction, which is normal. Rinne's test is then repeated on the other ear. To complete an examination of the ear, specialized auditory testing as well as a tympanogram should ideally be performed. A full ENT assessment should also ideally be performed, including an examination of the internal nose and of the postnasal space using flexible nasendoscopy. Assessment of the cranial nerves can be performed if indicated, and the examiner should also palpate for regional lymphadenopathy. For a detailed description of this, refer to the course Examination of the Neck. Following completion of the examination, the patient is thanked and the examiner again washes their hands.